So right now, a lot of the thinking about surgery for brain metastases and their recurrence is based on the idea that surgeons leave behind some cancer cells in the surgical cavity, and these are what lead to incidences of local recurrence, which happens quite frequently and can be prevented at least partially with postoperative radiation, either in the form of whole brain or stereotactic radiosurgery. But we wanted to test the idea that it's possible that at least some local recurrence events are actually caused by invasion of cancer cells outside of the surgical cavity into the adjacent brain. And so it's not that the surgeons are necessarily spilling cells, but they're just missing cells that are outside of the contrast enhancing area. And so what we did is we looked at the histopathology of a large cohort of brain metastases and basically patterned them based on what we see at the margins of these lesions, whether they're minimally invasive, so really a sharp border between the tumor and the adjacent brain, or a more highly invasive phenotype where we see either clusters of cancer cells or even single cancer cells invading outside of the main metastasis mass. And we essentially bucketed brain mets into one of these two groups, and then in a completely blinded way to what we had found, we coded the patients, retrospectively looked at what ended up happening to those patients, and we found that there was a significant difference in the incidences of local recurrence and even overall survival in the patients based on their growth pattern, in that the patients that had highly invasive brain metastases were much more likely to experience local recurrence and the shortened overall survival compared to the minimally invasive ones.